what we wanted to do today is a light agenda. If we get done early, then everybody can go and we won't tell where you are. We had talked last week about some things that would be in the general requirements and outside of the service definitions, and just wanted to take some time to go through those types of issues and see what needs to be changed in the general requirements for the waiver. So, I know, thrilling conversation, and I had promised Mary I would be as entertaining as possible.
You have a draft for us to review?
All 217 pages of the waiver?
No,
Not quite
the
yet.
general requirements.
No, actually, I've got some noted here, and I wanted to see if you guys had any that were missing, and then we can draft some language around them. Okay? So, what I did is I just started going through the waiver and looking at the things that would probably need to be updated, and just kind of wanted to get some feedback and see what outside of the definitions, outside of resource allocation, outside of outside of care coordination and the SIS, what is it that we wanted to change in the waiver? Okay? And some of these points are things that are in definitions that didn't come here because the definitions didn't need a huge rewrite. For example, supported employment has a 3-year experience requirement. And we've received a lot of feedback on taking out the 3-year experience requirement for supported employment staff.
Yes. Yeah.
So, is there any discussion on that one? I'm going out of order with the waiver, but just to kind of give you an example of things that we probably need to change.
That's within the service definition. I'm thinking too complicated.
It's within a service definition that we didn't rewrite.
Okay.
So it's not a huge.
It's a three-year.
There's a 3-year experience
Full-time.
for staff to provide supported employment. And what we're hearing is that it creates an access issue, especially in towns where you have a lot of your paraprofessionals, your direct support professionals are provided by college students who might not have that level of experience yet. So
What will be the appropriate?
open for discussion. Do you think the experience needs to be different than that for community networking?
What is the definition of experience in the waiver?
3 years full-time, direct and providing that service.
Working with somebody with a disability.
With an intellectual development is very specific.
So could it not be in any capacity, like as a DSP, where they have experience working with a person with IDD?
That's not my understanding.
Well, I know, but I'm asking, would that
Yeah.
be the appropriate thing? Is like you have some a year's experience working in some capacity with a person with IDD?
I mean, in my opinion, it is a little bit higher skilled service. So maybe it is, and it does have a higher rate. So I'm sure there needs to be justification for the higher rate.
What's the rate?
From actually having done this service myself, when I started off, I was a job coach. I had no experience coming in. I thought I rocked at it. So, I mean, to say, honestly, coming in, I think the things that I look for as I hire job coaches are people who are driven, who have a good sense of business, because you really are a salesperson. And so for us to put in requirements of working with, I don't necessarily need them to I can train somebody on the skill set of understanding people with intellectual and developmental disabilities, but I can't train some of those other aspects. And if we're talking about college students, once again, who some maybe work really well, they're not coming necessarily with that experience. And I think that you really have to have a sense that somebody has to be able to work independently and be trustworthy. And I don't know how you can write a definition around some of that. So I would just be cautious with that piece of it.
So you mentioned some of the things I think that Deb was trying to get to was like that community networking, because what you're describing there is somebody that could be a good networker, has a bit of business skills there.
And I have no problem with a certain amount of training that a person has to have related to intellectual and developmental disabilities, which are standard, I think, with most of us, anybody who comes into your programs, you know. I think there's a standard requirement of training, and that maybe this goes in that general section like we talked about last week of, it's true for all definitions, right? That you have to have these certain training requirements in. And because some of that is going to come with just being able to get to know the individuals, and you do have to know your community. You do have to know where the places to go to be as most successful at it, I think.
Because we're following on the heels of the discussion that we had last time, I think, whatever that was. The more specific we get, the harder it is, the more we exclude the potential for bringing somebody in to do the job that needs to be done. A 3-year skills or experience requirement isn't a bad thing. The problem is that we've excluded anybody that has other skills other than 3 years working directly with somebody with IDD. If you just drop the IDD requirement, because I've done that before myself, where I've hired people who have specific skills in the industry where we want to be able to place people and get people exposed. I can teach them, it's like you, I can teach them how to work with somebody with IDD, but find somebody that knows how to work in that particular industry with those skill sets, that's a little harder thing to come by.
It also has a little bit of a higher turnover rate than some of the other service definitions. So that if you're limiting it to 3 years, you're just turning through folks,
Yeah.
you know, right and left, and then there is nobody, you know.
Three years of skills in business and industry, working with people with IDT, or an education equivalent.
I think the education equivalent's good, but I don't think the 3 years, I think that's just too high.
Yeah.
I don't know that gives, that doesn't tell you any skill thing as towards that job.
I mean, my best job developer right now, she doesn't have a college education. I mean, she's out there killing it. I mean, she is really placing, phenomenal amount of people. And she just has a certain personality people cannot say no to. Yeah.
Well, a lot of that's relationships too.
It is. It's about learning about relationship building. And once again, I don't know how you can put that in a definition for a requirement, but it's what you look for. It is. And it is a high turnover field because I think, one, they're out there looking for jobs constantly for other people. Things pop up. And also other places see you working with them and recruit. There's a lot of factors out there because we don't have turnover much in our agency, but I have had it in that department because I think of different factors. You're working all the time, different hours too. So we have to, I think, be very flexible in that and not shoot ourselves in the foot.
Now you got a third shift job.
Yeah.
You got a third shift job and you get somebody with 3 years experience.
Yeah, I can go someone do something else for a lot more money.
Make a better paycheck doing something.
Yeah, I'm
Yeah.
sure. Yeah, so you guys, is there any requirement that we have to put any sort of years experience on that?
No, there is not.
How does that affect the rate, the baseline rate? I mean, I realize consumers could choose to pay more in their budgets, but there'll be a base rate that they can't go below. So and I apologize, I missed the rate setting meeting, but does that number of years of experience of the person delivering the service in any way impact rate setting on that baseline rate?
I can look at it, and I'm not certain that it does. I think that
if not, I wouldn't have
a lot of
proposed.
the rate is built around the other people you have to have as far as the job development and things like that. But I can look into it and see if.
Yeah, because I know in state personnel, very different than the waiver. Anytime you mess with years of experience, knowledge, skills, and abilities, it drops the classification of the position, which automatically drops the salary, right? And so you don't pay people that are not required to have as much education and experience as much money, which could be the reason this rate is higher than something like personal care. And rate setting, I mean, all of that kind of goes in the same vein in the financial world.
If
So.
I think back though, and somebody who's been here for a while, correct me, I don't recall there being a 3-year experience requirement for CAP MRDD.
No.
Correct. I mean, that's just the thing I wouldn't want to, I would not want to see that rate drop for something
No.
like this.
Do you remember where it came from? Why 3 years?
Do you know?
I do not know.
No, the concept,
PBH thing.
the concept is between respite and personal care versus skill building, habilitative service. There is an educational differential and an experience differential.
And absolutely, what Cindy just said is true in my experience in doing rate setting activities at DMA. The lower the qualification, the lower the rate that is paid.
But, I mean, I think if you're looking at with the rates between rehabilitative and personal care, the experience isn't necessarily, I mean, you have to have a GED or a high school
Staff
equivalent.
quals are the
You know, I mean, the qualifications of your staff is not different, but with the quality I'm looking for in staff may be different. But it's not written already different.
I'm not arguing the qualification
Yeah.
and the fact that the 3 years may be wrong. I'm just saying, as Cindy said, be forewarned.
They may.
If you propose an equivalent that describes and captures the unique experience that you're describing.
Yeah, like John said.
Community
Industry.
relationship, that's right. And you bring that up and you say that justifies the higher salary.
Right.
But if you do it based on educational or years of experience with a particular population, that would be a factor that DMA would consider when they're setting the rate, just in my experience.
Mine too.
Not
I think the way around it, saying that it's IDD experience in the workplace, is to really kind of word it's an equivalent of education and experience and expand the experience beyond just IDD supported employment. It's in the workforce, it's in the industry, it's in, just add a lot more things in that, which is what gives you the expansion, but it doesn't drive the rate down. It might actually drive it up, but it won't drive it down.
That makes sense.
Add the word preferred, goes a long way.
Yeah, that's right.
Give the job interviewer, the hirer, some latitude.
Yeah. This is a person-centered concept.
Well, the supportive employment rate was high too because you had to pay the person that was working with the client too. It wasn't necessarily because of the experience, because you paying the worker and you paying the client and you paying the other employee to be there with you.
You shouldn't be playing your client. What it is it's the employee, and then if you have a job development specialist who is drumming up business on the outside as well, that would be part of your overhead in the rate.
Well, and what you're looking at in that position too is having a versatile ability to do a lot of different types of jobs. I mean, that's one of the reasons I would think for a higher rate is because it's not all just type of, you're not going in and just working in fast food. You have people going into offices and coaching people on administrative type jobs. You have people, doing factory work. You have all sorts of levels that the person has to have a versatility and a skill set that requires a higher rate because they have to be able to do that. All sorts of different things.
We'll beat that one good.
So, am I safe in saying that if it doesn't affect a rate, that we take out the experience requirement, that if it does, then we word the language that it's a combination of experience and education?
Yeah, I've been using the word preferred. Yeah, prefer this.
For the IDD stuff, not the manager.
And or.
Okay. So
it's just a process question. As we consider these things today, can this go out? Because I'm not the most knowledgeable person on this particular point that we just discussed compared to members that I have. So that we can kind of say, here's what the group thought and...
yeah, I see it. You see it going out in the minutes as a chart.
Okay.
This is the requirement we discussed, and this were the comments.
And I made that comment to Renee, I don't know if I talked about it last time, but I thought that the minutes have been very broad and haven't necessarily line by line reflected when we make a specific recommendation around the service definition change. Historically, so I have to go back and rethink what did we say and submit it written, I guess. And I may be the only one that thinks that.
No.
Okay.
Yeah, I mean, if this process is going to replace specific input that we made on service definitions, let's at least put this out as a general input request for ones that have not previously been considered, such as the one we just did. ample opportunity.
Yeah, and
Input
especially for
on
the people who
requirements.
weren't here today because of the weather, trying to have something that's a little bit more comprehensive, because these are a lot of little pieces. It doesn't have a solid definition tacked onto it, or at least not in this format. So while we're on supported employment, if we are all good with that one, I have another question on supported employment, and that is actually writing into the definition that the expectation is that the individual is working in a job that pays minimum wage or higher.
And what else is in the HCBS? I mean, I think that it needs to match whatever's in there.
HCBS is also a,
But you know what I mean? Like,
Yeah.
The pitch is parallel.
Because I don't have the definition right in front of me, what I would caution about too is that we have a lot of organizations that have affirmative businesses where they have people who are, and I think if you put in there about the minimum wage or higher, but it doesn't matter if, for example, if I as an agency have a coffee shop and have people who are working there, right now, they can't be, there's something, and I don't have this in my agency, but I've heard feedback from other members who said that they can't have a worker with them the whole time. There's something about the definition that it goes against, as a provider, regardless of if I'm the agency and I'm a provider, but if I'm employing anybody, just like anybody else, I'm an employer. I'm paying them minimum wage, treating them just as any other employee, that shouldn't be frowned upon, because a lot of times businesses are out there in order for agencies to stay afloat, especially as they move away from maybe contract work, things like that. They're opening businesses, especially in your rural communities. One of our member organizations is probably the third largest employer in their county. And so if you don't count the work they're doing, or you put limitations around that, then it really hurts that provider, and the individual.
and I think where that came from is in the definition. It talks about the agency cannot be, okay, and I'm trying to do this from memory. There's language about what constitutes supported competitive employment.
Right.
And that you cannot use supported employment to subsidize the job or the payment of the person.
The job or position would not exist if the provider agency was not being paid to provide the service.
And so, because the provider is the employer, I think some of that.
It has, because of that, and there was a memo that came out from CMS on supported employment, and I can get you that citation. We had to be very careful that we didn't have people creating jobs so that you had somebody just to do the service and you were paying that person's wages out of the supported employment. So it had to be, if you chose a different agency, I want the ARC to do my supported employment at the place where you hired me in the coffee shop, it can't be that you say, no, we have to be the job coach. It also can't be, we're going to base your hours on a 1-to-1 ratio with your supported employment. So if there comes a point in time where you don't need 40 hours a week of supported employment, you need to get it authorized anyway, or else we can't afford to pay you, therefore we're going to cut your hours back. So it's not a matter of you can't have a worker for every hour you're there. It's the fact that having a worker for every hour shouldn't be what determines whether or not you can get paid or employed for that hour.
And there may be some confusion at the MCO levels of
We can try and
operations
make that
and things
clear.
like that, because I know at least 2 members mentioned that they have run into problems because of that.
Yeah, there were scenarios where we need to be authorized for 30 hours a week, or else
They're not going to work.
Carrie can't be employed as our receptionist anymore because we can't afford to pay her.
Right, and that's not the case, but what if she needs, every time that she's there, she does need assistance, then she should be able to be authorized because she needs that level of assistance to be able to do the job.
She meets the criteria for the service definition, medical necessity
And
criteria.
if she chose to leave that job, that you would hire somebody else in her place.
And it wouldn't matter whether or not they had innovative qualifications or
Yes.
not.
Right.
And I think with that, with the medical necessity, and I think you bring up a good point, because that's come up several times too, and I don't know if anyone else has had issues. You know, what's medical necessity when it comes to a person with an IDD? And that sometimes on the MCO level, we're hearing some odd things there. I mean, anybody else seeing that?
Well, supported employment, particularly supported employment, it's that viewed as and it should be viewed as a step-down service, but there are individuals who will always need a one-to-one, basically,
It's like
and that's been very hard to justify.
And I think you also have to take into consideration whether or not it's the appropriate job too, because I do recall a case where we had someone who could not stock the shelves at all
Right.
physically, would not be able to stock them ever, but they thought if they could get the job and the staff would do well, that they could ultimately transfer into a customer service position. It sounds very weird, yes, the weird things happen to us, I think it happens to everybody in the room. But at that point in time, you want something that the person, how much are you going to get out of the job if you know that you can't even participate in that part of the job?
What about the issue of micro enterprises? And when you bring up this issue of minimum wage, I know a young man who's got I think it's like a saw sharpening business. I know, IDD with a little mental health thrown in there, but he plays with sharp instruments all day. So he has some supported employment, and I know some individuals with micro enterprises that in fact have had to go all the way to Office of Administrative Appeals with their supported employment issues. But aren't those things that are somehow in this definition?
Microenterprise is, and I think microenterprise is a little bit different in the fact that you are your own boss and this is your business. You are supposed to be submitting your business plan to make sure that it's a viable business. For example, if you only had one saw blade to sharpen a week, you probably wouldn't need 40 hours of supported employment to do it. But when you're actually talking about competitive employment where you're being hired by someone else, it shouldn't be at a sub-minimum wage.
It doesn't break it out by micro enterprise in the definition.
There's a little line around assisting a beneficiary to develop and operate a microenterprise.
So do we need to be clearer with that?
It, you know, I just think that we want to make
Needs to
sure
be
that
real broad.
competitive, yeah, that people don't then say, well, they're not making an equivalent of minimum wage because they're in their own business, because let's face it, a lot of people who own their own businesses, when they look at it, sometimes aren't making minimum wage themselves because, you know, you have good times and bad times in business. So I think that would be the important thing, not to make sure that that's not held against them, because if I'm a UM and I say, well, I look at the plan, well, there's no way they're going to be making at least minimum wage, so this doesn't count. We just want to make sure there's something that doesn't hurt them like that.
Yeah, and I'm sorry, I just want to agree with what she's, I mean, UM staff would look at that way, as that this wouldn't meet the criteria because they're not making minimum wage without a really good understanding of owning your own business, and that might be a piece rate. I mean, if the saw blade guy, he gets paid on the number of saws, not on how many hours it takes him to do the saws. So there's lots of different ways people make money. Sometimes it's, and I don't know that that needs to be in the definition or the general description, but probably on the educational platform without, hopefully, our new resource allocation, we're not looking at medical necessity at all, and we're not looking at something like that as long as it's within the budget, and it's a safe and healthy job, and legal.
We got to be careful with that because medical necessity does have to be in there for a Medicaid service if you want to be in compliance with the waiver. So the service still has to be considered medically necessary.
I thought we decided that the clinical description was what defined medical necessity, not the actual service authorization. Because that's going to be really important when we talk about educating people.
No, but I think when we talk in terms of the definition in a waiver, that you need medical necessity, if the medical necessity you have a clinical description that goes along with, it's still, you have some sort of criteria for explaining why the service is provided through Medicaid. I may be going into the legalese portion of the program.
I think you probably, I mean, when we think about how we explain, if you really want a paradigm shift, now, if you want it to stay like it is, okay. But if you want a paradigm shift, you start talking medical necessity and UM, then MCOs are going to get hung up in that URAC criteria that they're also required to have, and then they're going to want to put fences around everything and say, well, I can't approve it because whatever reason they could deny it for. I mean, I think so far, and I'm not disagreeing that, you know, we have eligibility to be on the waiver, we have a level of care that's been determined. You know, all of those things are also medical necessity. You know, we've said the person meets this criteria. They've chosen the waiver instead of institutionalization. I mean, there have been checkpoints along the way. I do believe you could count towards a medical necessity determination without making it around the definition of the service. That could be the clinical description, it could be the level of care. There's lots of things that make medical necessity that don't have to drill it down to the definition.
Right, the fact that they have qualified for innovations in and of itself, doesn't that denote a level of
The level of care has been determined.
I think we're getting more into the policy descriptions because in promulgated policy for DMA, the services have statements on services have to be medically necessary. So
I
I
got,
think you may be getting the semantics on the issue.
so I guess with policy, things like this is a big policy change, and but if I understand, the intention is that the requirement have minimum wage.
To justify competitiveness.
That's right. That's what you're trying to differentiate here. If somebody's in supported employment versus other day or work options, other day or work options may have a piece rate, and that may be allowable. But you're making a policy decision in this service definition that this is for people with real, at least minimum wage jobs. Is that right?
And I think that the definition says competitive employment. I think it's just taking it a step further and saying competitive employment is a minimum wage job.
And I think
That was my question. I mean, the scenario is if you have somebody who has a one-to-one type support, who has significant disability and wants to work and under other circumstances be able to get a job, but based on this, if their impairment is such that it's going to take 10 times the amount of time for me to do the same job that somebody else would do, there's a break point where, yeah, you pay the minimum wage and it's no big deal, but at some point it gets to the point where a particularly small employer is going to say, you know what, as much as I would love to hire you, I can't. So we've just precluded that group of people from being able to get jobs, and maybe it's answered or addressed someplace else in the waiver. But that question of,
Well, that wouldn't preclude the employer from giving the job.
well, but economics does.
But they're not paying, they're only paying the employee regardless. The
Right.
support staff is coming from, unless
But
the
it's-
agency is both a job
If
placer and the,
If we place on this a requirement that those jobs must be minimum wage or better,
well, most employers aren't going to pay below minimum wage, period. You know, if they're,
that's where
unless
my
they're
ignorance of
a
the system here.
shelter workshop, they're paying minimum wage or above for any
Okay.
competitive job.
Yeah, I would agree that, in the sense, and I think that then you're looking at, for example, if I have a day program that has sub-minimum wage certificate and we have a work component to ours, then it would fall under day supports at that point, where they could still do it at a sub-minimum wage.
Well, that was kind of my question.
But-
Is it covered someplace else?
Because employers in the community typically aren't gonna have a sub-minimum wage certificate.
Does that go even go through HCBS? Well, that's a different conversation.
Yeah, I don't think a sub-minimum wage in a competitive employment situation would pass HCPS.
No, and it shouldn't.
No.
That's
That was my question.
Okay.
The only
Thank
other
you.
random sport employment things that I had in my head is it limits the age at 16, which is fine, that's the age in North Carolina, I think. But for some of the folks in high school that are doing the internships or transitional programs, they are 14 or 15. So I don't know how frequently that comes up, but I imagine here and there it might. And then the question of internships, I don't know if that needs to be put into here or not, or if you think of that under community networking. It's just not anywhere, and I don't think it needs to be.
Yeah, I almost think internships would probably, if it's an integrated environment, would fall under community networking. As far as the.
I don't think so.
What?
What if it's a paid internship?
It's dicey because you're talking internships at any level.
Be paid.
DOJ,
Or
or
DOL.
DOL jumps into the middle of that pretty strongly with or without a disability.
I mean, it's almost a matter of the policy.
So it sounds like something we need to.
Look at.
Yeah.
Now, as far as the transitional programs for 14 and 15,
You just
That
have
may-
16 in there now.
yeah, that may move over into the school conversation.
It may, but they may be doing it outside of school hours and outside of school.
Okay, we can look into that too. Okay, so we good on supported employment? Any other thoughts on supported employment? Welcome, Dave.
Hi, guys.
Do you have anything you wanted to add in? We're just talking about the general things that would be outside of the definitions that have been scheduled to come to the group. And we ended up in supported employment, which is further down the list, so we'll go back. And we talked about slots being point in time instead of being encumbered for the entire year.
Say that again, please.
We had talked previously about the slots, how there are a set number of slots in the waiver, but we serve a set number of unduplicated people. We also have the option of saying, we serve these number of people, but we only serve so many people at a time. So right now, we say we can serve 12,488 people over the course of the year, and we don't limit it to a point in time. We could say that we anticipate serving 14,000 people, but we will only serve 12,488 at a time.
So it's like returning to the previous language of several years ago when the LMEs did resource allocation, and they had a certain number of people that they could do, and if somebody died, they could bring somebody on the next day, not have to wait for a whole new plan year to utilize the remainder of that slot. Is that right?
Yes.
You mean virtual allocation?
Virtual allocation, thank you. Yes, yes. Virtual allocation, not resource allocation. Resource allocation, new, virtual allocation is old. Yes.
Can I ask this
We're dating
question?
ourselves.
And this just may be ignorance on my part, but if we're moving to a different way of the budgeting process, right? So say it's allocated, and I don't know how you do your 12,488, and it's probably not times $135,000, expecting that each person's going to get it. So, but if I'm only using, say, 40,000 in my budget, and you get maybe, say, 10 people who are doing that, and you're under that, can you not bring in more people because you're not fully, I thought that was part of the reason for going into this model too, is that then we can use that money to get more people's services.
And wouldn't it make better sense, rather than to tag it to a specific number of people, tag it to a percentage of the overall budget available?
There's actually, this is a technical thing within the waiver itself. The waiver gives you an option of saying, first you have to tell them how many unduplicated people you plan on serving in a waiver year. And if you serve over that amount, and you haven't submitted a technical amendment to them changing the number, then they're not going to give you the money
So they
for
actually-
those other people.
So they actually tag it to a specific head count.
We have to choose how many people we're going to serve. Right now, we say we have 12,000 slots, and we can serve 12,000 unduplicated participants over the course of the year. Then there's another box that says, do you have a limit on how many people you serve at any point in time? And we say no, because we want to serve all 12,000 people at a time. There's also a box that says, yes, we will only serve X number of people at a time. So we could raise the number of people we want to serve, and then say we will only serve 12,000 at a time. So that way, if you move out of the state, I can move carry into your slot.
What happens if you underreport that number?
What do you mean if you want to?
You say we're gonna serve 12,000, and we serve 11.
You would probably be asked as to why. I mean, you put in your numbers for a 5-year, since this is a renewal waiver, we put it in for a 5-year period. So we said, right now it's static. We serve the 12,488. And there's fluctuating, what?
I thought that was.
It had to do with previous allocation in 2007. And then we were given another 250 slots from the legislature. So over time, the number, and then we added in what was in innovations originally. So that's why it's not a real number.
How does that play with your supports waiver?
We have an issue because we have state law that says we have to operate the waiver under an aggregate funding. And we've never got to that point. So the question you're asking about, so you budget, you serve more people in it. One way I think that you can get around that is by saying you would have, you obviously have more slots available than you were serving, which gets CMS to come ask you. There's a technical way around it. But I think one of the things we need to go back to CMS and ask is how can, in this environment, can we, how should we manage this? So I think that's what you're getting at, is how do we make that
Yeah,
happen?
well, and that was kind of my question. Is this a federal boundary that's been placed on this, or is this more of something that we wrote in the original waiver?
Probably federal.
This way that it's written, what I just described, is how the template for the waiver is. So these are our options on what we can do. We can either just say we serve an unduplicated number X, or we serve an unduplicated number X, but at any given point in time, we are only serving Y, where Y can't be more than X.
Wow.
Or you serve an unspecified number, no more than 1248.
You
You can't say we will serve them all.
No, you have to say how many people you anticipate.
Yes, you
serving.
can.
This is how many people you're going to touch this year. And are you going to say that at any given point in time, I'm only touching 10 people? Or I'm touching 100 people?
CMS part, that seems counterintuitive. If I know I have a budget of this much money, and I know I need to keep a reserve just in case of, to cover people that are coming and going, so that there's that ability to move them in. You know, again, somebody may use a lot, somebody may use a little, but I may be able to get more people in based on how that all.
That's probably why for all of these years, we've said this is how many slots we have each year.
Yeah.
Does it
Because
require
of this.
legislative action to get more slots, or is that something that we can
Yes.
just arbitrarily pick?
We cannot arbitrarily pick.
So you're stuck at 12,000 without legislative action, is that right? Or 12,000 or whatever the number is.
12,488.
Yeah, but you have to have money. They have to,
You have to get the state match to get the federal match, right? So we're really kind of stuck at this number until there's legislative action. Is that accurate?
Unless we can show that serving the same,
It's really two places in the application, is it not? One is the number of slots. The other is, which has nothing to do with dollars. In Appendix G of the application is where the dollar section is. The CMS approves that rationale. Is
in
it
J
not?
and I, that gets into
J.
financials.
But it probably relates to that kind of thing. But what we're trying to get at, if I understand, is the, excuse me, the virtual allocation, doing it like that, like we did years ago. LMEs were very effective at taking this amount of money at that point in time, and if somebody moved away, or as long as they stayed within that allocation, all was cool. So that point in time did relate to both number of slots and, in a sense, but it also related to total dollar value. So we kind of, at that point in time, combined the two functions of the application. But then what happened, if I recollect, was with the waiting list and tightening up as happened. So Dave, you know the answer to that question.
I mean, actually, this wasn't in state government. I think the virtual application happened for 2 years, worked well for 2 years. Then we began going down a different path. And when we went down a different path, we stopped doing virtual allocation. virtual allocation worked, but if I recall correctly, the way it worked was we actually had more slots than we had funded that were available.
And you would have to do that. You would have to have more people that you're planning on touching, but you would only touch a set number of people at one time.
The problem at the same time, though, is that would not allow for if Cindy and ECBH were outrageously efficient in how they did business, and people decided that they were willing to not spend as much in their slots in their process, they couldn't actually add more people onto their waiver.
Not unless we did a technical amendment. And just remember that it has to go from year to year and
Right,
over time.
But that goes to the point of having more slots available than we actually spend. To where that is, because typically you wouldn't be, I think the way the virtual allocation works is that nobody wound up saving enough money to add another 50 slots. It was really 3, 4, 5.
3 or 4 people.
And that was held at the state level and reallocated when people had that ability during the year, I think. So I guess the point for us is that we have to go back and figure out how technically we could do this to allow for that to happen. But I think we've got, eventually the legislature is going to ask us, I suspect that they'll ask us about this whole aggregate funding issue.
So the idea is we want to maintain cost neutrality,
Correct.
but we want to spend all of those dollars
As much as possible.
to serving the greatest number of people possible with that
Well,
cost neutrality.
Rose, you were probably at the
You
division.
probably know the answer.
Doing I'm just looking at you now, after you were here. Weren't you here when the virtual allocation thing was going on?
Well, I wasn't involved in the
Oh,
waiver at
yeah,
that
sure,
point.
go ahead, right.
I really was not. I was in that LME world.
That's right.
I think what you're saying is I would agree based on my little bit of memory of that period of time. But I think it's very complicated because it's not as easy as just to say, well, we have this much money and we have this many slots. I think there's a lot of value to opening up slots when people step out of them mid-year. But I think you have to be very careful how you manage them and that it's really clear how the MCOs are able to do that.
I did manage the virtual allocation for New Center at that time in history.
You're way older than I thought you were.
I am, I'm 45. So I did do that, but it was truly virtual. We never got a capitation. So there was not a risk on the LME.
No risk.
The risk was on the state. And so that's really different today. In this environment, you would capitate us with the risk included. And that's a different animal too. Because if I add those people, and I think they're only going to spend $30,000, and they end up needing 135, now that's a different ballgame. Because my risk is that's different. Although I'm all for a virtual allocation, I think we would definitely be able to add some folks and diminish those wait lists, which is atrocity to happen.
From the Senate, maybe I'm getting this wrong. The cost neutrality issue is more of a legislative concern than it is a waiver concern.
Cost neutrality is a waiver concern because there's a couple of points to it. One, if your waiver is not cost neutral, CMS will not let you operate it.
Right.
So we have set our upper limit at 135, which is 111% of what it costs for the average ICF placement. Our average cost for an innovations waiver participant is probably around $60,000. So if everyone spent 135, we would not be able to have cost neutrality. And what it does is it factors in your waiver costs and your other Medicaid cost versus the average cost of an ICF placement and the other Medicaid costs related to those people. So it is a waiver issue, but it's also, within the capitation doesn't come out to be $135,000 per person.
We're so far off of the cost neutrality issue, and with the individual budgeting process, I don't think we have any chance we're going to bump up against that cost neutrality issue. It's really what you're describing as cost neutrality is cost neutrality waiver to waiver, right? And that really is a PMPM issue, which CMS probably doesn't really care about. Or how much money, if the cost goes up because of PMPM you know, 3% increase per person, then just pay it, that's your commitment.
That's right.
And at that point, legislature has the ability to set the ceiling. So that
The legislature doesn't set the cost ceiling, they set the ceiling on
already
the
capped.
slots. Right, yeah.
So, I mean, and once again, please correct me if I'm wrong. One of my thoughts was coming into this is that we were looking at, doing some of these changes so that we were able to serve more people. So how does that factor into this whole process? So is that coming to the technical amendments, that piece of it doing? Is saying, look, we did this is how much we've saved this year, this is how much hasn't been spent, we'd like to turn this into slots? Or how does that work? Maybe that would help me understand that.
So, just as broad scope, let me try this. I think there are a couple of ways it works. One is that if we can do this, if we can figure out a way in which this aggregate funding, I'm sure it's the right word to describe it, but the aggregate funding made a lot of sense in a different world. It was a lot easier to think about, and that was that if the process saved money, you were able to add more slots. Well, that's managed care in its, you know, sort of global view. Problem is that managed care in the DC waiver is that you manage C separately than B, which has a very different way of doing business. It's not an entitlement to it. You have slot-based services, so that theory about managed care, the way you think about it on the B side, doesn't work on the C side. It only works if you can do this, which is that essentially aggregate funding. It is really, I think it's an important concept. And it's an important concept because it helps people think that if you have a waiver slot, and I say this, I've heard families say this, is that and the virtual allocation did it, is that people were less inclined to say, for instance, I had, you know, I'm just using this example wild, I had, you know, 30 respite hours, I'm willing to give up 10 of them because I never used them, right, in the process, if I thought that somebody else would have the ability to access that. But frankly, if I thought it was going back to the general fund, I don't think that's such a great idea, right? So that's, so that it really is a culture driver, I think, if you can do aggregate funding. But it doesn't result in significant amounts of new slots. Our thought is that the way to guarantee significant new slots is that if the General Assembly is assured that we're going to manage within the budget, they see that, they can do it under managed care generally, but I don't think they're still quite sure that we do so under the C side. So it's a chance to prove to them, we know exactly what it's going to cost us. If you give us X amount of slots, we know exactly what that's going to cost. And you're not only, you know, it's a PM driver, but we show it. So we have to get there first, and then I think the next step is showing that we know how to do it, and then you have them invest more into this way. It also, again, just one more thing, it also gives us, the more predictable we are, and the better we are doing analysis of how we spend state funds. It also might give us the opportunity to think about converting some of the state funds that we have that are pure state money into match money for additional waiver slots. It's dangerous because the only way to do that without having the potential to hurt people that are not on a waiver is to know exactly how much money you're going to spend with that. So there are some other longer term benefits that we may be able to gain from this.
And I think we got into this, I'll make a statement and then I'll ask you, Bob. I think we got, it was really good conversation to get the education out there on the slots. I think the question was, originally, do we want to confirm, do we want to try and keep more people by allowing those slots to not be encumbered for the year? But to do that, we have to say we're going to serve more people, just the same number of people at any point in time.
And the current formula that you mentioned a while ago was, you have a $135,000 limit and then you had what utilization? You had some figure.
That's 111% of what the average institutional cost is.
That excludes our state facilities and the ICF average together.
Do they get recalculated when the state institutions got their rate increase?
I would have to look at the appendix I and J to see. It's what you do is when you submit a waiver, you project out for the 5 years of the waiver, and they calculate.
So that just being, I know that all the state institutions got rate increases, not the private people, but the.
So is the average ICF based on state institution included or just community ICF?
State and
Maybe it's the state, because the state are the only ones that got a rate increase.
Right.
And so when we submit this, it would be good to make sure that's recalculated to demonstrate this maybe it changes the percentage, because their rates went up.
usually what we do, okay, yes,
In the math way, that having assistance.
okay.
Make that percentage be better.
Well, and Deb, going back to your original question, I think, I mean, from what I'm hearing, we all would be in favor of whatever we have to check the box to make sure we can serve as many people as possible. You know, so if that's that third one of, at any given point in time, we're limited to this, but we will serve this many people overall. If that makes that happen, whatever that needs to be to make that happen, I think is what I would be in favor of.
I have a question. What options does somebody that's not getting a slot have? I mean, do they definitely not get any assistance until somebody moves away or drops out, or what?
Somebody doesn't have a waiver slot, what our options are available. There are pure, that's not the right way to say it, there are General Assembly appropriated state funds that are available to people that do not have an innovations waiver slot. There are some B3 services that are available for people who are Medicaid eligible. Those are Medicaid funded services, we talked about that are Medicaid eligible through the LME MCOs.
And then state plan services, which are just regular Medicaid state plan services, personal care, home health, OT, PT.
And probably the most expensive and biggest one of all would be ICI, which is a state plan services. So there are other service arrays available in terms of the intensive community services that people tend to look for. The waiver is the one place that that's available.
Are the people made aware, the people that aren't getting a slot, how are they made aware of what's available to them?
You hit a last part.
How are they made aware that those are available?
That is an LME MCO function. So if you show up to the LME MCO looking for services, right, and you have a intellectual developmental disability, the first side of that is that there is not entitlement to those services, Medicaid. They are to do the intake, to have you on, if there are no services available, make sure that you're on a wait list for those services, you do that. But if there are services available, either through their state-funded services or these other options, then the LME MCO is to make those available. But in terms of, if you haven't shown up at the LME MCO, then
Hope you show up at one of our chapter meetings.
that is a paid announcement by the Autism Society.
Well, and I think for some people who, you know, I know, and I don't think this may be true now, but because in our MCO, everybody who's receiving any state service has a care coordinator, but hopefully they're making sure they're on a wait list for the innovation slots, because some people aren't even though they may be receiving a state-funded service, if they don't have a care coordinator, and with the new way the registries run and the old, you know, there was people in the past that we thought were on an innovations waiver, CAP waiver at the time, who were not, or had gotten removed off a wait list and nobody knew. So you were thinking they're waiting all of this time and they weren't. And then if they get on it now, they're at the bottom of the list, even though they thought maybe for 10 years they've been waiting. So that's a real problem too, is getting that education out. And I know in different communities, people try to work with letting schools know, because the school system really is a great place to get knowledge out about being, this is what you need to do to make sure that you're getting, you know, that you're in that service array, or going to be eligible at some point in your life.
But can there be some sort of a booklet or notification when some child qualifies for an IEP, where they would be appropriate to at least request a waiver slot, that they be notified what they need to do? I'm just afraid that there's just people who don't go about it correctly, and then they're just not informed, and they never get to the appropriate contact people. An IEP person, I mean, someone who gets services with an IEP would be, if there was a book, they always give you your due process rights, maybe they could say, have you applied for, and how, and what you need to do.
When
So
they
there
were-
used to be a slot prioritization policy, procedure that each LME, MCO had. Now that we're MCOs, is that prioritization policy still exist, and is it still required by each MCO?
You're not directing that question here, that's their meeting.
There's two things, Bob. There's the waiting list and slots that come available every year, the turnover slots, when people have vacated slots, or if we get new allocations of slots. Those slots are first come, first served. So that means the waiting list is actually being pulled from the person who's been waiting the longest, which is, it's not.
Remember, when we move to the innovations waiver, there also is a county formula.
Okay.
Don't forget that, because that makes people think, well, I've been on the list the longest, and you might have been on the list the longest, but you live in Pitt County, and you're not going to get a slot until number 187 comes up, because Pike County and Terrell and Gates and Northampton and Dare and all those have never gotten a slot. So you're last in line.
And there's an emergency, people that catapult to the top.
Or there's reserve capacity. So that's what I was
MFP is
trying to-
different. There's lots of little different veins, little tiny numbers in them. But like the 50 slots we just got, nobody in Pitt County got one because of the formula.
Because you have to make it geographical.
Policy promulgated formula. How do you see it? I don't know where that came, honest to God, it wasn't there in the cap and mar waiver, and then it showed up in innovations. So I don't know where that policy came from, I just know that it is, part of the requirement is based on the formula. So it's the time on the list and the formula today.
County
So I think what
County
we
formula,
just was
yeah.
taking a note of is that we're going to take a look at that. It's a geographic requirement that is a CMS requirement about geographic distribution, but the question will become, does it have to be county-based or not? So,
Well,
It is.
if you look at life guardianship as an example of how that might function, we already run into issues where a slot is allocated to a county, and anytime somebody vacates the slot, refilling the slot from inside the county becomes an issue. If there's any kind of a hang-up or any kind of a problem, those slots may go unfilled for a significant amount of time. And I would argue that rather than go county to county, because now you're really slimming it down, I would carve the regions up in much larger geographic regions, which gives you greater potential to serve, to make full use of the slots in a faster fashion. And now you're looking at a county specific and all the effort that goes into determining inside that county who is available, who's eligible, who isn't eligible. I think it just complicates things much more than it needs to be.
So to me, the bottom line, sorry.
go ahead.
And then the second part, there is reserve capacity, which aren't a whole bunch of slots, but they're slots for emergencies that you can move ahead if you have somebody who is in, imminent harm or has no place to live, things of that nature. You can use the emergency slot. There's MFP, which is money follows the person to get folks out of the institutions. There's very, very few Cap C age outs for kids who are on the Cap C waiver that might be more appropriate for our waiver when they turn 21. And then we have 5 military slots. Five military slots.
With all the,
They're specifically for individuals who have, if the family is involuntarily transferred to North Carolina and their child was on a waiver in another state, we could give them a slot. And I think that I have only allocated one since the waiver started. And the question is, do we want to, look at that at some point in time and determine whether or not we want to reallocate those 5 slots?
My
for
question is like, how well was that made known to all the bases? Because surely.
Bingo.
I've had families that moved here that was on a waiver at another state and only one.
Exactly.
Yeah,
That's not right.
Military.
I think that's probably an education of the basic.
Yeah, that's not right.
Meetings which are to, modify the system are important. If there's no education and notification of what the system is for people to get into it, then it only helps the people that are already in it. And that's a huge thing. I mean, I am certain there's more than one person in the military that, maybe the military's not telling them. But what about all the people who don't even know what to do? What sort of communication or education is there to let people know how to properly get situated? And then after that, I don't know if it's, it doesn't seem, once you even get on the list, that there's a fair way to get services.
Specifically for the military, there's the EMF or EMF.
But I mean, that's a lot of different.
That's what they do, and hopefully they are making that connection. I know, again,
One.
at the autism site, we do that presentation at Fort Bragg, and we've done it at Camp Lejeune on an annual basis, along with the FMP staff, to let people know. I didn't know there was actually a specific military, but they.
That you
do
weren't
know
informing them.
what to do if they go to that program. If they don't go to that program, like to the EFMP.
One point on a bigger picture, just about the education issue. I think we heard that a lot in our the listening tool. Part of that strategy and struggle is that so where the natural places where people would find out that aren't connected to our system are young children through CDSAs. So that's one place that we know we can make an aggressive effort to make sure that people understand that. School systems, obviously, to do that, but school systems are, and this is not a knock on a school system, this is just understanding, are notoriously bureaucratic and different. We have 110 school systems across the state, and I would say that you've got 110 different ways that school systems operate in terms of educating people. We can do that with DPI, and we will certainly make that outreach with them to remind them of the LME-MCO system. Also, is part of our problem is the LME-MCO system has evolved and changed. We have people that had historically close relationships with people in the LME-MCOs that, because of just geographic size, have changed. So a little bit of that is continuing that education, making sure that, for instance, the county commissioners and the social service agencies understand who the right contacts are and how to make that happen. But there's a lot of targeted education that we have to do. What we don't know how to do, and I don't think we can, is some sort of broad mass communication to where we're doing the constant advertisement on TV. We can't afford to for one. So it has to be through these targeted efforts. But I think it'd be helpful for us to hear back from you over the course of the next several months of places where you think targeting that education would be would non-traditional places that might help us.
But
one of the trying to help the DD Council with this. We know that if a parent or well, I'll give you a story. I was just on the phone last week with a woman, and she is her sibling has a disability. Her parents have been the primary caretakers, but her parents are now experiencing early onset Alzheimer's, both of them. So they're moving toward increased need for support themselves. She's taking on more supports for her sister and her parents, and is really struggling with what to do. And she Googled and came up with the Council on Developmental Disabilities, which is what happens and we want to see happen. So we're also helping in this way. We recognize the need to rethink the information as the system evolves, to be helpful to, as at least provide information, help point people in the right direction, provide some information directly. And I know that's something the department is also working towards, taking a look at. If folks end up there, can that information be one way to help people have a better understanding of even who to get to? So I was able to help her understand what an LME is to a degree, but help her get connected to her local management MCO to begin to make some of those contacts. And we talked a little bit about Medicaid and she, to get her up to speed. So I think there is a need for that, and we're actually going to see more of this trend now with siblings. In fact, we have an initiative where we're really focusing on brothers and sisters who are now going to be moving to more caretaking roles. So we know it's there. I think we're trying to figure out some solutions, but I do think it's going to take partnership going forward, and I think that's also going to need to be with the MCOs and the providers in the network, but also the non-traditional maybe. She had talked with a physician, and she was expressing her really being overwhelmed. And unfortunately, we want to see this change. The physician's response to her was, it sounds like picture a lifeboat, and who's all in this lifeboat with you? You got one can of food. What do you do? And that was a pretty grim way to handle this. Basically, what he was saying is, you need to take care of yourself, is what he was saying to her, and go down a more traditional route. So we know we need to be educating the other folks that they've talked about and mentioned. We've got to get that information out to these other networks where individuals are involved and have not maybe been traditionally connected in a way. So.
There's still a work group on communications.
Yes.
What they're doing.
Can I go back to the allocation of slots? We talked about how you have 10 for military, talking about a regionalization, a regionalized concept. It seems to me that anytime that you have, the smaller those allocations are, the more competitive it gets for those slots. And the more potential that you're going to have to tell lots of people that you're going to have when they might otherwise be able to. Is it allowable to create whatever size region you want? I would suggest larger than a county, so that in effect you have a pool of slots in a particular region, and then keep a number of slots available at large for issues that come up, whether it be military or circumstances that come up, that these are the slots that we have available, and as soon as somebody comes up that needs one, we're going to park that in that particular region. And when one opens up in that region, we'll pull it back to be used someplace else, but that gives you a pool of resources that broadens it out and says, somebody that might otherwise not be able to receive because we used up all the slots over here, 10 military, what happens when the 11th person shows up and says, I need it?
And the hard thing with that is right now the slots are allocated per LME MCO. Each LME MCO has a set number of slots, a set number of reserve capacity slots, and we have the military slots because we couldn't guarantee that you would have, one person in the military end up in Smoky. So we couldn't assign those out. You have to, if you want to create a reserve capacity, you have to tell CMS how you're going to reserve those slots.
So we do have a power to do that.
Yes, we can set reserve slots.
Because one of the things that, when Chris was just mentioning about the family who's aging out, what we're also seeing, and what I've seen, I'm sure other people have, and this goes back to the prioritization issue too, if you've not been on the list long enough, people, who have Down syndrome and Alzheimer's early onset, and seeing that happen, and where then they're forced into a much higher level of care of need because they can't get the supports, because it hits, and then the family's left, well, they can't continue on the way they've been doing it, so either they're not going to stay in the residential program they're in, or even in the day programs, things like that, because they need so much more support. When you see that decline happening, that happened with us at our organization, we really worked hard to keep this individual in our program, and the group home did for about 2 years longer than it would have naturally happened, I think. But she didn't qualify for, she was too far down on the innovation side, and thank goodness her family had money where they helped pay privately for some extra supports. But with that's not always the case, and many people don't have that. And yet she wasn't apparently at a high enough level to qualify for emergency slot, because we tried that route. So I guess, my question would be, knowing that this has become a real issue as we see people with Down syndrome living much longer, and having, Alzheimer, I think the statistics is at least 50% are going to get it and it happens early. You know, maybe if we have that ability,
It's 100%.
I'm just throwing out because
Yeah.
prioritization with us not having a prioritization tool, once again, I've seen where people are getting slots who maybe don't have that much need because they've been sitting there long enough. And then you see these people who really, really need it aren't getting it because they're so much further down the list. So, I mean, I would just throw out that I think if there's a way to, you know, I hate to say that, but I do see that there is a prioritization issue where I've seen people who I've wondered, wow, they're getting a slot, but yet this person's not. You know, the method to that, the madness there.
But that's a historical problem.
Would you be describing something that would say that first come, first served is not the way you think we should be doing this?
No, it should be, because if you do first come, first served, then you're going to get the disability in its natural occurrence. Every birth of a disabled child isn't a severe child. Some births are much milder. So if you get them date-based, then as they naturally occur in the population, then they would get their services. The problem is when you had it prioritized to the level of need, all of those non-needy, non-severe people never, ever, 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 ever got service. So the fact that you ever had that kind of a priority screwed the whole list up. You know, you've got to open up 10,000 slots to make the date-based list make sense.
And that only is true though for people who get on it at a young age. You know, if I've had this intense need and had it for a long time but didn't find out I should even be on a list and just now get on it, then chances are, I don't know what that balance is. I didn't think about it that way, so I appreciate that point because
Right.
it's true.
Well, if they took
That some
135,000 times 12,000 and put it in the bank and then held it in reserve and funded it every year over and over and over, so it just stayed there, that money, then as the needs got more and more severe, there's that reserve account to pay it.
We do not allocate $135,000.
But if the legislature would, just
This is
saying,
a
everybody,
decades-long problem.
write a letter.
It's not going to be solved this afternoon.
Thank you.
But you asked the question, what would, how do we educate people? Each LME had a policy at one time on how they did it. So it was based on longevity or on urgency of need. And what would make sense is for us to have a public, transparent policy on slot allocation. It was posted on the the Innovations webpage on the state and on each LME MCO that this is the policy. And if you want to educate people, that's where you put people read the website.
Shouldn't it really be like an algorithm where there's a severity factor and a length on the list factor? And based upon that, it comes out to a number, and then, because you could be on the list, but you're not severe.
Right,
And-
you'll
and
never get.
You shouldn't be getting services just because you were on the list when someone is very in need and they haven't been on the list. So an algorithm would take into account both of those issues.
Like Chris's example.
And then
Mom and Dad
my
all said
other
that
point
also.
was, I don't know how much public service announcements there are. I mean, you know, in the way of.
It's on how late at night you're up.
Just like, you know, through the news media and, you know, public service kind of free commercials, that kind of stuff to just inform people. Because like groups like Autism Speaks have kind of really put out information that's kind of gotten a lot of notice where, well, I don't really watch TV, but I don't really see anything about how I would, I mean, I made myself learn, but if I'm just, say, a normal, you know, or even a person who's not that educated, or in a rural environment, or in a district where there's not many people notifying me with, yeah, then I'm never gonna know. I'm just never gonna know.
You know, you created a formula that was based on a number of criteria, severity, length of time on the waiting list, you know, all the different factors that algorithm that at least ways gives you some idea that there is a light at the end of the tunnel somewhere.
One of the risk of how to say this right?
Just say it until.
Say it and apologize.
Just spit it out and you can backpedal later.
They'll cover you.
It's a lot harder with Mary here. The
Turn off the
backpedal.
camera, turn off the
Yeah.
camera.
I think, and I'll say.
We'll have a discussion at break.
I think having an algorithm and getting to a point where we're at there would certainly be the better method. To think that between now and the time we start this waiver, that we
Yeah.
would find an algorithm that would work, that would not at some point in time, and I would think within the first time somebody used it, have somebody wanting to go to court about how the algorithm didn't actually do what we said it would. I think that's the fear I would have on that. But I'm not suggesting that your idea that somehow having, at the very least, ability to discretion within slot allocation that goes beyond just first come, first serve. First come, first serve is intended to do exactly as Mary described, to make sure people aren't penalized because of a milder disability. That what I try to continue to say to everybody we talk to is that a mild developmental disability doesn't mean that somebody doesn't have significant needs.
Exactly.
So that shouldn't be something that disqualifies somebody. I think one way of helping is to deal with this geographic issue that's based purely on county. Another is to think about if there's some flexibility that we can offer within the first come, first serve at the LME MCO level. And then as we become more sophisticated to think about working on an algorithm, that will become particularly important, I think, if we did have a significant amount of new slots that were allocated here. And so I think we need to, what I would say is I think it's a great idea. We just need to continue to work on it, but maybe not get it into this waiver yet.
Well, I think it's really fair to say that this isn't going to be a one and done.
Yeah.
I think that there are going to be things that we added now, and then there are going to be things that come up later. Things that we know we want to do, but we're not there yet. I don't see us as ending after this.
I don't know that there's any state that has a good model. I've never seen one in any other state that has a good model for managing this issue. Every state has it, that has a C waiver for this population.
Oh, not
Everybody
true.
has a good algorithm that everybody can agree on, because
Not true.
the level of care to get into this C waiver is a broad range of presentations. And so the other impact on that, there's two I just want to mention. And then I won't say anything else about this. How do you migrate people from what we have now to that? Because that next person in line might move to the back. And they will go to court over that, I feel pretty sure. And the other thing is there are financial implications as well. Because the most needy people cost closer to $135,000 than the others. And that really has a big financial impact on the capitation, the LME.
Right, so less people are then getting services. And then,
Really,
even if you even almost had a percentage versus an algorithm of so many get this percent, or out of new ones that are gone.
Most of it drives it to the top of the price.
Right. You're right.
There's no waiting list in California.
Why is it never easy?
This is not an easy solution.
There's no waiting list in California.
No, but they're on the I-waiver too.
I think this would be, you have to say. that
But the idea that we can't solve it,
is a good point for a 5-minute break.
Yeah.
I wasn't going to say that because
I always do.